of mental health related care. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded on the IHEA website afterwards. Before we begin with the webinar today, I just wanted to run through a couple housekeeping items. If you're experiencing any technical issues during today's call, please type them into the chat box at the bottom of your screen. I'll be able to assist you. Everyone on the line has been muted except for our speakers today in an effort to eliminate background noise. We will be holding all questions until the end of the session when we'll open for a facilitated Q&A portion. I'll now pass things over to Panka. Panka, over to you.
Hi, everyone. Thank you for being here. I'm Panka Benchik. I'm a postdoctoral research fellow at the University of Chicago, and I am the founder of the Mental Health Economics Special Interest Group. We started this group in 2019, and it's at this point has over 140 members across the world. We are really happy with how much is going on in the group. So if you're already a member, then maybe that's how you found out about this webinar. If you are not yet a member, we would love for you to consider joining. If you are an IHEA member, the membership is completely free in the special interest group, and I'll just pop some links in the chat. Most of our focus is organizing webinars like this. We create a bi-monthly newsletter that collects all new working papers and published papers on mental health economics, and also disseminates conference and journal submission opportunities. Thank you.
Thank you very much, Panka, and thank you, Chanel, for the housekeeping. My name is Giulia Greco. I'm an associate professor at the London School of Hygiene and Tropical Medicine, and I'm very excited to introduce you to Judith Simon today. So she will be our speaker. Judith is a professor of health economics and the head of the Department of Health Economics at the Medical University of Vienna. She also holds a visiting professorship of cognitive health economics in the Department of Psychiatry at the University of Oxford. And without further ado, I will pass it over to Judith. Thank you.
Thank you very much for the kind introduction. Thank you very much for the invitation. I'm very happy to be here. And I just wanted to ask, as originally this webinar was due to be at 3 p.m., but because of the time change in the US, it happens now at 2 o'clock in Europe. I'm wondering whether many people missed this. Is it possible maybe to send out an email info to those who registered for the event to inform them? I'm sorry, we could have done this before, just wondering. Otherwise, we are recording the meeting, I guess, and people can watch it. But
absolutely, I can send an email right now.
Yeah, good. This would be great. Thank you.
Yes, thank you, Chanel.
So I will share my screen, and we agreed that I will take the questions in order of time at the end of the talk. So the talk will be about 45 minutes, and but I think if you have any questions, type it in the chat box, and then we will deal with it. So the question is, are you? I will turn on the presenter mode. Are you seeing the right screen?
If you go to display setting, as you did before.
Yeah, I know. So you don't see the right.
Swap is, yes. Perfect.
Now you see the.
Yes.
Good.
Thank you, Judith.
Okay. Thank you very much. This is always difficult. So today's webinar is presenting 3.5 years of work of 10 partners who joined forces to execute the PECUNIA project, which ran between 2018 and 2021. And I actually would like to tell a story. First, I would like to give a little bit of background to the project. What was the topic we tried to address? What are really the, I would call, uncharted heterogeneities in economic evaluations we all know about, but we all ignore in our current work, I would say, or at least most of us. And what we tried to achieve by developing a new costing framework and tools, and eventually a new outcomes framework and relevant tools. So the PECUNIA project, as I mentioned already, ran over 3.5 years, and we received 3 million euros grant funding from the European Commission to execute the program. There were 10 partners from 6 European countries participating in the project, and it was coordinated by the Medical University of Vienna, by myself. These are the principal investigators who participated and led different work packages and different work streams, and we were supported by a very experienced and diverse scientific advisory board. And again, I would like to acknowledge also other EUFAMI representatives who supported part of the project. Thank you very much. Their input was really helpful. So background to the project. When we initially planned the project, we already knew that, and this is not, I think, new to anyone on the webinar, is that healthcare costs are rising, and cost of mental diseases are actually responsible for about 14% of overall health expenditure. So it's a very large sum. There are multi-sectoral impacts, so-called spillover effects of health and health interventions. This is not very specific for mental health, but mental health is a very good example where these are really important. And therefore, conducting economic evaluations just from the health and social perspective may not capture all the necessary important outcomes. So therefore, we argue that actually implementing the societal perspective as a general approach for mental health economic evaluations is very important. We have also, we are experiencing limited implementation of economic evaluation results. We developed these, but still in many countries, they are not really used for decision making. And one of the reasons is the fragmented funding for health care services. And really, if you save in one segment of the healthcare sector money by a new intervention, but another segment needs to pay for it, usually the whole arrangement falls through in these fragmented systems. And I worked now in Austria, previously in the UK, and this is a very good example, which often happens in the non-centralized Austrian healthcare system. So we have multinational estimates. This is something else that is becoming more and more important, that we have a lot of clinical studies which are conducted in several countries. And then when it comes to the cost effectiveness evaluation, then we are a little bit puzzled methodologically that we may need nationally relevant estimates. On the other hand, we also want to have methodologically standardized comparable costs across the countries, and also outcomes and cost effectiveness estimates, but it's often lacking. We don't have lack of standardized international costing and outcomes tools. This is generic. And we don't know the magnitude of heterogeneity when we are assessing costs and outcomes between countries and sectors. So we really tried to look at these different types of heterogeneities first as part of the project. This is an example I'm using from Hodge and Diva back from 2017, who looked at, in Ontario, service use data from early psychosis intervention program users. And you can see that not just the time horizon matters, whether you are really looking at resource use over 12 months or over a longer period than 12 months. You can see that the distribution of the different sectors between hospital cost, healthcare costs, other community cost, counseling, legal or housing service costs, but also you can see that overall hospital and other healthcare costs roughly take about 50% of the overall resources used, and the other 50% is actually coming from social care and justice costs, etc., etc. So this really showcases, I think, as a beautiful example how important societal perspective is. We then looked at what is the situation in the different European countries in our original concept paper, and we found that there is a lot of heterogeneity already in the required costing perspectives. So like in the UK, for example, we have health and social care sector as the main perspective required. In Austria here, we have healthcare, patient and lost productivity costs. It's more of a list, but then there are for example, the Netherlands, where societal perspective is the standard. So there is quite a bit of variation already between the countries here. Therefore, we can understand why an economic evaluation conducted in one country is not really transferable to another country. What is the other issue? I mean, something we very rarely talk about when we write a paper or we do an analysis, we very often say, we did this analysis from the societal perspective, but what actually societal perspective means differs very much between studies. So we would move beyond, definitely in a societal perspective, the healthcare cost and the health and social care cost, but very often this is what we see, that any study which includes lost productivity costs already would state that they are looking at societal perspective. Then sometimes patient costs are also included, and in even rarer cases we would have informal care costs and family care costs, but there usually it ends. And this real societal perspective, where we are taking the intersectoral costs into consideration as well, for example, on the education sector or on the justice sector, this is very
Judith, you're unmuted, Judith. Okay, thank you.
What happened?
You got accidentally muted, but now you are unmuted.
Okay, thank you very much. I haven't touched anything, but did you hear what I was saying? Okay.
Yeah, yes, just the last few words.
Just the last few words. Okay, thank you very much. So another thing which very much differs between countries, and this was also a big revelation when I moved from one country, being a health economist in the UK and arriving to Austria, is that we have many countries in Europe who use economic evaluation as a fourth hurdle, but how important and how systematically these results are taken into consideration varies very much between countries. And there are only very few countries which actually have national unit cost programs which help the conduct of robust economic evaluation. So you can see that in Europe, we have this in the Netherlands, in the UK, Germany, in Finland, but that's about it. All the other countries don't have these publicly available data sources, and therefore, if you conduct economic evaluations, they are very much not comparable. They will differ where you manage to get the data and many other ways. So this was another thing we tried to, I'm wondering. Can you hear me? Okay, good. So in terms of unit costs, I think one of the best examples I would like to show today is the cost of daycare. We were working on a multinational trial and the economic evaluation of the trial. And this was one of the resource use items we had to cost. So we looked at the UK was participating, Germany, the Netherlands, and Spain. And we looked up the unit costs from these countries, trying to find the cost of a unit of daycare center use. And what we found that it ranged from anything of €8 in Germany to 460 euros to the Netherlands. So you can imagine if we are trying to cost this multinational trial and we have so different unit costs in the participating countries for the same resource use items, there must be something going wrong here. Yeah, but we very often don't do this detective work. We simply accept this is the source, this is what we got, and we use this in our evaluation. So then we tried to look up what is the definition of these services, and we were only able to find this in the UK. In all three other countries, we actually could not identify a matching definition. So I will now go one by one, and this is what you can see, that there is already a heterogeneity at the description level of the service at the so-called unit of analysis. This is what I will use and refer to in the rest of the presentation. Then there is heterogeneity in the unit of measurement, which is also causing some of the changes. So while in the UK it was per client attendance, In other countries, it might be per hour, per therapy place, per day. And in one of the countries, we could not actually identify what this unit cost was referring to. As one of the early studies here in Austria, we also tried to look up that for those countries where national unit cost programs are available, whether they are using the same methods and or do they differ. This study was published in Value and Health back in 2020, and where we have already published results, you will always find the relevant references on the slide in case you are interested in further detail. So here you can see that we used Austrian data. This is the same data, and we deployed different analysis methods, ones from Germany, ones from the UK, and we compared it to the Austrian market price recommended for the cost of a general practitioner consultation, the unit cost. And you can see that between the German methods, which was about 16 euros, in comparison to the Austrian market price, which is about 43 euros, we found an almost 180% staggering difference. So you can imagine if you are evaluating an intervention which very much influences the number of GP visits, then depending on which unit cost you are using, it will tremendously influence your overall cost effectiveness conclusion as well. Beside the costing side, PECUNIA also looked at the outcomes side of cost effectiveness analysis, and we looked at, as I think everyone on this call most probably know, the EQ5D instrument as one of the currently most commonly used health-related quality of life measurement instrument. What is the situation? This slide is already an updated slide from 2020, and you can see that depending on which type of EQ5D we look at, the 3L or the 5L, there are different availabilities in Europe. Overall, back then, and I will talk about this when we started the PECUNIA project, there were 17 European countries, not just EU countries, but also EFTA countries and the UK, which actually did not have either a 3L or a 5L value set for the EQ5D. So this again tremendously influences how robust economic evaluations you can do or whether it's feasible. Another issue that came up, and I think we are all who work in mental health economics are aware, is that sometimes these traditional outcome measures like the EQ5D may have a limitation in terms of the measurement space. They may not be able to capture all the important outcomes for the patients for mental health care interventions. We also, when we even move beyond mental health care and just generally consider economic evaluations, we know that if we have a multinational study, we may not have the same options in terms of patient-reported outcome measures or PROMs, because some may not exist in some languages, or the value set has not been developed, or maybe they have only an adult version but not a child version. And this kind of metadata is very limited currently about PROMs, especially for the purpose of economic evaluations. And one other thing that is very important, or becoming more and more important, is that maybe our unit of analysis in terms of outcomes should not just be the patient, but especially in mental health care, usually a lot of the impact, a lot of the burden falls on the carers. And therefore, it might be better to use unit of analysis, both the patient and the carers together. And when you do this, then you have to find prompts which are able to do that. And again, this information is more limited. One of the aspects to broaden this measurement space is the capability aspect. And today I don't want to talk about this too much, but this is another area where we have a lot of research. And I would like to highlight two publications which refer to many of these aspects I just mentioned. So the overall PECUNIA objectives were to harmonize costs in terms of the unit of analysis, the unit of measurement, and unit cost valuation methods, and to make comparable unit costs available more broadly within Europe. The other aspect in terms of outcomes was to investigate a little bit better the factors of heterogeneity, to make sure that they are more available across Europe, the same way as the unit cost, and that they are comparable. So what did we do in PECUNIA? We planned a project which ran across 8 work packages and alongside 4 horizontal activities. We had 4 work packages which looked at different sectors: health and social care, education and criminal justice, employment, and patient, family, and informal care. And we had 4 horizontal activities: identification, definition, measurement, and valuation, which was actually the backbone of how we planned our research steps. And we conducted these horizontal activities alongside all 4 work packages. We also had a specific work package for outcomes, and then we had a work package for validation, and 2 work packages kind of standard for more the management and organization. So what about the new cost assessment frameworks? I first would like to talk about the PECUNIA Care-Atom and coding system. So within PECUNIA, we had a costing and an outcome concept. On the left-hand side, you can see our costing concept, and on the right-hand side, the outcome concept. First, I will focus on the left-hand side. As I already mentioned, we had a stepwise approach where we started with identification and we built on each other. And I will explain in a second what we mean by these 4 steps. And we did this across several sectors of the economy, the usual ones, health and social care, but then we went into much broader territories as well. So as part of identification, first we developed the service and resource use item list. Then we developed a specific coding system, which we used for this item list in order to really get rid of this heterogeneity we have been experiencing so far when looking at service costs. We developed a new resource use measurement questionnaire, which is matching these items and codes. So it's completely international, and actually it's not just mental health specific. And we developed matching unit cost calculation templates, which can be used for calculating any unit costs with already a homogeneous, harmonized way. And we also started a unit cost compendium with the work we have done, which is a live tool and can be broadened hopefully in the future. So this is what I just described. And here I would like to show that we also designed, we had 5 countries which participated in the development of the tools: Austria, Germany, Hungary, the Netherlands, and the UK. And we had a country, Spain, which was actually kind of our guinea pig. They were the ones who were validating the developed methods and looking at both cross-country and health technology transfer assessment. I would like to highlight that there are 2 initial publications that have been published on the more unusual sectors, I would say, which were part of the PECUNIA project: education and criminal justice, if someone is interested how we implemented these steps in those projects. But beyond that, I would like to go back to the beginning, the beginning, which was in 2017, where we first met in Venice, actually, with the collaborators, with the partners, and we put together our head that how could we illustrate the issue we all feel there is, but no one really systematically investigated this before. And what we felt that we could illustrate kind of what's happening to patients who have a mental illness, which often is episodic, which requires different pathways of care. And then within the pathways of care, we have subunits. And this is where we already started to have problems, what is really the superiority between the subunits. So this is a very initial illustration. And what we wanted to say, I have children, and for me, this reminded of the Lego blocks, so that you really can there must be some units of analysis which are transferable between countries, which are internationally homogeneous. And if we manage to identify these and attach cost to them, like here it would be illustrated with the different colors of the Lego blocks, then eventually you could build up every single service in any country from these universal Lego blocks. And this is what was our task, to define these Lego blocks and try to attach value to them. We went back to the modified care matrix of the organizations, which is a work from 1999 from Tornikov and Tansella. And in our PECUNIA project, we focused on the micro level, the service units, or we may call them basic stable inputs of care. And you can see that in the production function, so we actually really went back to basic economics, that in the process of care, in the production, we have input, which are the resources, staff, facilities, equipment, consumables, medication, overheads that go into the provision of care. And these are usually the ones where we need unit costs attached to it. But when we actually look at patient care, which is the throughput, the process of these services, the activities, which we call they are the interventions or the procedures that are carried out, then we can see that this is the information what usually we are able to collect from patients. So there is already a discrepancy between the initial input information and the activities information we are usually able to gather in our economic evaluations. And then, of course, we have to measure and value somehow the output and the outcomes, which might be intangible or tangible. So this is where actually after 3.5 years of work, we arrived with the PECUNIA Carathon. You can see that we stopped at the level of pathways of care, and anything below it, we developed a completely new concept. And here you can see this better, where we were able to define these Lego blocks, these transferable units of analysis, by cost type and international coding systems. So we have inputs of resources which are actually related to service provision, and we have inputs of resources which are related to personal input, which can be time or money. And in terms of the service inputs, I already mentioned which are these in terms of unit costs, and which are the pieces of information we are able to collect when we are doing resource use measurement. And we try to match these. How we were able to do this, we used international coding systems, and I will on the next slide very briefly explain this. So we actually started from language, we moved to coding, and then I will explain how we move back again to language so that we can use these methods in economic evaluations. Then we have the output, which is actually the care realized, and we have the outcome both at organizational person level or the monetary value for societal assessment. So the costing concepts was basically 4 steps. Step 1 was a harmonized identification of the services, which we did via literature search and country reports. Then the second step was this harmonized definition of services via disambiguation and using international coding systems. For this, we deployed the DESDE LTC system for services. But if someone would be, for example, like to code an intervention, a specific intervention, then simply you can add to this DESDE code an ICHI code, or International Classification of Health Interventions codes. Or if you would want to define the unit cost of a professional consultation, then in addition, you can also define the type of the professional who is providing this intervention. So it's a kind of like a pyramid, starting with the service, building on the intervention, and then the professional who is providing. In step 3, we developed the resource use measurement, which was based on harmonized clusters of services. We developed in steps 1 and 2, and they are using homogeneous coding, and they have homogeneous costs. And in step 4, then we actually valued these homogeneous codes and costs with so-called reference unit costs. So how did we do step 1? Identification. We conducted several literature reviews for each sector. One, we did some grade literature review, and we also went through country-specific literature and incorporated anything the different party partners in the countries could identify. We put together a preliminary international sector-specific item list, which then was deployed in the 5 developing countries to expert review. And the experts were asked to look at clarity and accuracy of the listed items, their relevance for service provision, their completeness, and the existence within the national context. What we found, so here you can see the 4 sectors, 4 sector lists, but some of the lists were double sectors. So health and social care sector, we, for example, identified that we are not able to separate these 2 sectors because in some countries, one service might be provided by the healthcare sector and in the other one, the social care sector. So we ended up combining these 2. And the same for patient, family, and informal care. You can see how the systematic literature review, the number of items that were identified. This actually, we highlighted here, this is from our Austrian experience, how many additional items were discovered by different countries or specific publications. We then looked at the national grey literature searches, and here again, you can see the additional number of items we discovered and were able to synthesize. When we subjected this to expert review, for example, in Austria, we had 18 experts who went through the list and assessed it. And you can see that 88% of the items were considered clear by the experts, 38% were deemed important, 4% of the items were actually suggested additions. So the original list did not contain all the service items that are currently provided in Austria, and 14% were considered as not existing in Austria. So there are services which were on the list but currently not existing in Austria. I have to say again that here we focused on mental health care in Austria. So this was the case study we used in PECUNIA. You can see, if you are interested in further details, how these steps were carried out and how the survey and what the findings are, then there is a recent publication which you could look at. What did we learn? Firstly, we learned that already by what a service is, and what we understand under services, what the definition of a service is already problematic and challenging. And language itself often fails to adequately describe the services. So for example, the same word for a service, it can be as simple as hospital care, may mean something completely different in one country than in another one. And therefore, we realized that if we continue with names and language words, we will not be able to get through and break through this heterogeneity we have in wording, in languages, in the units of analysis. So this list then underwent for health, social care, education, criminal justice sectors, a very thorough investigation for ambiguity, vagueness, and confusion of the words. So this was almost like a linguistic and health services research assessment of all the items. What the colleagues from Cos found, who carried out this investigation, is that they did this at 3 different levels. They had unit of analysis level, where they find that 89% of the items were accurate, but there were about 11% of the items which were actually not services. So we had 11% of the items which had nothing to do with services, but they were either interventions or professionals. Then in terms of target population, there was already much less level of accuracy, only 52%, you can see here. And at the definition level, where we tried to attach a code to these services, there was an even smaller level of accuracy. Only 41% of the items, how we had them, how they were described, it was possible to attach a specific DESDE code to the service. So overall, we had only 23% accuracy level. All the rest, it was not possible to code. This is what happened, explaining a little bit differently. So we looked at the scientific literature, we collected items. Then, for example, we had the item day hospital. this went through this disambiguation process. We had a definition which was international consensus, and then we used the coding based on the care atom I previously presented, which sector it belongs to, etc., etc. I come to the code in 2 or 3 slides. And basically, we worked on this service item until we were able to accurately attach one code to it. And then this was the code we used in the further works, kind of back translated it, and was used in a resource use measurement instrument later. These are 2 examples. What do we mean by the different levels of care and how we did it? So if I take a healthcare example, you can see that there might be a hospital. Within that hospital, there might be a department, but the department would not be a service itself, because this psychiatry department, as in this example, may have 4 services provided at the microorganization level, which we are at in PECUNIA, by different care teams or basic stable inputs of care. This might be an acute unit, this might be a day hospital, this might be an emergency room, or an outpatient service unit. And this would mean that you have very different unit costs for each of these care teams. And this is very important. So we found our Lego blocks. We went down until the level where we would say that an acute unit at the Department of Psychiatry would have a fairly homogeneous unit cost across different services. And the same for criminal justice. Here you can see, for example, a police station and the relevant different care teams and services provided. And these were then already really homogeneous by enabling us to really allocate just one code. This is the PECUNIA coding system. I will just quickly go through the whole slide. So you can see that the code itself defines which disease area, which patients are served by a service, whether the service itself is on an outpatient basis or inpatient basis. Here are the different options you can define. What is the age of the patients who are usually, or the service users who are usually cared for by this service unit, which sector it belongs to, and eventually some additional qualifiers, whether the outpatient care happens at home or in an outpatient unit at a hospital, etc. And as I already mentioned, you can combine these. Another paper we published as part of PECUNIA simply describes this coding system in much more detail, and we use psychotherapy as an example. So if anyone is interested, you can read about how the coding can happen. PECUNIA RAM instrument. So this was the next step. This is our step 3, the measurement. We are already talked about identification and definition, and now we are at the measurement, harmonization, step 3. You can see that using this list and the really homogeneous units of analysis we managed to identify and code, we basically went through different steps, and each work package designed a module for the given sector based on these steps. This is what you can see already in step 5. Then we harmonized these modules together so that all modules had the same wording, the same recall period, etc., etc. We developed the preliminary instrument, which then underwent several further steps. So we had the preliminary validation and piloting with professionals actually at the beginning, and then we had a think aloud exercise which we conducted with previous service users or their carers, families and friends. And we adopted the instrument based on this feedback. Then the instrument underwent a formal translatability assessment, which basically allows us that the wording of the instrument is formulated in a way that if someone would like to use this RAM instrument in a different country, but the instrument is not available in the given language, then it should be very easy to translate the instrument in a really matching and linguistically valid way. Then we developed the final integrated instrument, and this is the one which is currently available as part of one of the final tools on PECUNIA. I will show in a second how it looks like. What we did not manage to do, and I mean, we did not have the time, and it was not even in the plans to do a formal psychometric testing of the instrument. This is actually has not been done often for any resource use measurement instrument, and this is something we would like to do in the future once this instrument is deployed. The background to this whole development process was also, so a lot of detective work went at the beginning into this project. Some colleagues, some partners really looked up what are the aspects of a resource use measurement framework that needs to be harmonized to reduce heterogeneity. And some parts of the instrument, which are, for example, focusing on lost productivity, there was a thorough systematic literature review done and some expert feedback provided to see whether there is already an existing instrument that is suitable to be used. We did this actually for all the modules. So we did not ignore the existing instrument, but we concluded that other than the lost productivity sector, all the other sectors needed changing if we want an internationally valid, homogeneous instrument, which can be also used with the other PECUNIA tools. And this is how the final multilingual, multisectoral, modular, self-reported adult questionnaire looks like. It's a very nice long title. So we have several modules. It's a modular instrument, which means that depending on the perspective of the evaluation, if anyone uses the RAM, you can decide that you don't want to use all the modules, but you only want to use the health and social care ones, or you are interested in health and social care and other out-of-pocket expenses, or someone would like to also know about informal care, but not about safety and the justice system. So it's really very flexible to use depending on what are the needs of the economic evaluation, but what is standardized are the questions, the orders, the type of resource use that is measured. So it means that any study that uses the PECUNIA RAM for resource use measurement will be directly comparable with another study which also use the PECUNIA RAM. And what we need to be very transparent is that which modules were used and which sector resource use was collected information on, because this initial naming of direct costs and indirect costs, etc., this is also confusing. So we would advocate as the PECUNIA project, after learning a lot about costing and resource use measurement, that it's much better to be transparent about the sectoral costs that we are collecting information about. And this is how the tool looks like. Very simple at the moment. It's available in a few languages, in the PECUNIA country languages. It's freely available for non-profit purposes. This is the link where you can look at the sample copy, and also you find registration details if you are interested in using it in the future. Currently, it's a paper-based version, but of course, as any questionnaire, it's possible to develop online versions and program it. So after this measurement step, we then moved on to the fourth step, valuation. Here, we tried to develop reference unit costs. We have two tools we developed for this. One is the PECUNIA reference unit cost templates. These are Microsoft Excel based. So again, we are trying to use at the moment softwares and tools that are very simple to use in any country. And we developed, following the PECUNIA Kerato model, we developed templates for costing services. Depending on what type of costing is used and how much data are available, there are 3 different types of service templates. We developed template for measuring, for valuing personal time. For example, for informal care or helping at home. productivity loss, and tangible consequences. So we have 4 different templates, and in terms of the service templates, a few different versions. These templates allow both using primary or secondary input data. So it's also flexible in this way, depending on what are the possibilities of the researcher. And they are accompanied by data collection sheets. If someone decides to collect primary data from service providers, then you can use these sheets to directly contact the information, which then you can feed into the costing templates, calculate your unit cost. And if you collect these from several providers, then there is a so-called raw data sheet, a third step where you can combine everything and develop an overarching average reference unit cost. Good. And once these reference unit costs are basically developed, they are fed into the PECUNIA reference unit cost compendium. So we have 2 tools. One is for calculating the unit cost. The other one is to make this unit cost available for research and all other purposes. This is the workflow. We developed recently a user guide for the templates. It's quite a document. If you decide to use these templates, then you will get the user guide with it. And based on this user guide, it should be fairly easy to work out how to develop independently by yourself a new unit cost in your own country. I will not go into more steps in this, just again show you that there are 4 different types of resource uses. So you have to first decide on which type of resource use you are dealing with. Then you have to familiarize yourself with the templates, with the user guide. Then you have to decide what kind of data do you have available or are you willing to collect in order to develop the unit cost. And once the unit costs are developed, we highly recommend, and this was a very important step we initially did not consider so important, is the validation of your unit cost. So once we developed this unit cost and then we deployed these initial numbers on decision makers and ministries, etc., we learned that some of them needed to be revised. This has nothing to do with the templates themselves, but simply the input data that were used. And therefore, we highly recommend that this is done. And eventually, all unit costs used by these templates will end up in the PECUNIA reference unit cost compendium. Good. I already talked about this. This is just to show you very briefly, and I'm sorry that it's not sharper, but I used snapping. So this is the best I could do. These are very big Excel spreadsheets. So that was the beginning. Maybe I show you, this is module 1, which is the description of the service. It's also possible based on this to develop the code we were talking earlier. And eventually you develop your unit cost. You are also able to inflate it with common methods to a common year you need it. And at the end, this would be the unit cost ready for external validation. What are the joys of using these templates? That they were developed with harmonized and transparent methodology, and they even contain an inflation module. So we really can bring everything to the same common numerator. There is a modular setup also here. So it allows flexibility in the costing approach and the data sources you use. There are complementary detailed user guides now, which just have been developed, and they were also validated, pilot tested for HTA and cross-country transfer, and this turned out to be positive. They are linked tools with the PECUNIA RAM, with the coding system. So you really, it's like a family of tools. You can use it, use the RAM in your trial, and then you develop the unit cost according. This is a publication, the validation work package published initially about the health technology assessment they were using for estimating the unit cost. But these are not actually the validation results yet. This is about how we defined the topic. And there are further publications coming out, both about the templates themselves. These are currently in the process of development or submission, and also about the validation results. And finally, the reference unit costs. So here, I just would like to showcase one example for general practitioner contacts, dental care contacts, daycare center per day, nursing home per night, and support hotline per contact across the 6 PECUNIA countries. So you can see that even with this level of homogenization of the methods, we still have quite a lot of variation. Some of it is linked to purchasing parity, obviously, but we did not want to adjust them to PPPs because they need to make sense in the national context, of course. But some of it is also linked to data input, and I will very briefly mention this at the end. But these are not the final unit costs, these are in the compendium. I just show you. This is again a snapshot from the compendium. You can see that we have here the resource use item we costed in potentially the national language, depending on which country you are looking at. These are, for example, from Austria. And then the definition that really defines the age group, etc. sector. You can separately see the sector, the funding source, whether it's private or public funded services, and all the rest. So you have metadata, we have common years, and you can see the unit cost. And here you can see the comparability kind of results published again, I think 3 days ago. So it's just the right time for the seminar. And I see Julia on the screen. This means I'm 47 minutes. So I will take the next 3 minutes or 5 minutes because I started late to talk about the outcomes. These are the strengths of the PECUNIA RUCs and compendium. So really, these are comparable, validated RUCs. They are unambiguously defined. They are connected with the other PECUNIA tools, which are really intuitive and user-friendly at the current version. And we really want this compendium to be a living document for the scientific community. So we hope that you will use these templates, and we will get this unit cost back, and then we will really have a fantastic tool internationally. I will not go through the example. I just wanted to show what happened, how we identified the services, then how we coded them, how we defined them, how they are included in the RAM instrument, what are the unit costs for them. And here I finished the cost part. So we have a new conceptual framework, but it's not mental health specific. So this is very important. We use mental health as a case study because it's a very broad area, but all the tools are usable for other areas as well. And we really, I think, managed to bridge methods between health economics and health services research. There are some certain heterogeneities remain, and this is mainly linked from input data, but this is not something you can change unless you can change your policymakers and data providers. And one more thing is, it's not fully societal perspective. Still, if we consider that we had not looked at transport as a sector, for example, or environment as a sector. So there are some sectors which I would say would still need to be explored, and hopefully in a PECUNIA too we can do this. And very briefly about outcomes. So here now we look at this. We had 3 tools developed: a PROM compendium, a pan-European EQ5D value set, and the supranational one. And I think in the interest of time, I just would like to highlight that why we think this is important to have a pan-European or supranational. First of all, because we have several countries which don't have EQ5D value set. Second, there are HTA processes which are now going across countries, and you may want a tool which is able to give international level decision framework and not just nationally specific. And I think this basically summarizes this slide. The methods we developed, and this is the most important, does not require individual data. but requires only the national value sets developed and the relevant algorithms, and these were combined. So this allows a very easy update if a new national value set happens. This is how the results of the new pan-European EQ5D3L look like in terms of distribution. This is the range that the pooled utilities ranged. And when we looked at supranational value sets, we tried to define country clusters which are very similar to each other. And if you happen to be a country like Austria, where we don't have an EQ5D value set, you can see that still very often the UK's value set is used. But this is not something that is necessarily the right way to do. It's just something we happen to do because we don't have a better option. Or very often it's not reported what value set was used, or nothing has been used because you could not basically develop a utility value. So we looked at country clusters. We did a literature review, which are the different aspects that influence the utility valuation of a nation. And we found several different aspects mentioned in the literature. We synthesized these with a point system, a score system, according to criteria adopted from Currency 8L from 2015. So these were validity, reliability, international feasibility, international comparability, and inclusion. And this is what we ended up. We have 5 final aspects based on what we developed: the country clusters, culture and religion, language, healthcare system typology, healthcare system financing, and socio-demographics. And these are our country clusters. These are, again, publications currently in development. So hopefully soon you can read all the details how we did this. We have 5 clusters: English-speaking, Nordic, Central, Western, Southwestern, and Eastern European countries. Here you can see which countries belong there, and here you can see which countries currently have value sets and which one would be the one basically recommended to be used if you happen to be a country in this cluster, but you don't have. The methods used are the same for the supranational, and here you can see how they compare, for example, the Central Western cluster. I will not go into, because this would be another 10 minutes just to say. So what is the best? If you have a multinational regional trial and you are looking for a best proxy, then we recommend to use the supranational value sets. It's easy to update. And the final tool is our PROM-MH compendium, which, again, based on a gigantic literature review, a relevant publication with all the details just came out also at the end of 2021. We identified 204
Judith, you are on your final minute because we have 2 minutes left.
Absolutely, and I'm on my final slide. And this is where we extracted 34 different types of characteristics for metadata. And we assessed also the different aspects I already mentioned for multi-person, multi-sector, or multinational and economic evaluation purposes. Here are some sample copies for you, but again, this is the link where you can look at the sample copies, you can access it. And this is the overall link. And with this, we have the 4 tools. They are ready to be used. And I hope this presentation contributed that you understand a little bit better what they are meant to be for and how you can use it. Thank you very much.
Thank you very much, Judith. It's amazing. It's an impressive amount of work spanning so comprehensive, 360-degree holistic. I think we have maybe we have time for 1 or 2 questions. If anyone in the audience, also feel free to unmute yourself. If you have any comment, or if not, Panka, do you want to? Do you have any question while?
Julia, I know you had one, so feel free to go ahead before we close out.
No, yes, I have loads. So first of all, maybe Judith, we can also organize another webinar where you maybe go into detail about the prompts, for example.
Yeah, I'm very happy. And I just see that there are some people in the waiting room. So I guess they are the people trying to join for the 3 o'clock webinar, but I'm not gonna talk again.
We can do another webinar. We can restart.
No.
No, my question was was about if you ever had like double counting with all of the different instruments that you may, if you are accounting for double counting, if you ever experienced that. In terms of costs.
Instruments.
Or the costing, the resource.
Yes, we don't have double counting. So this was an aspect we very much paid attention. So what we try to achieve is that we don't have double counting between cost and outcomes, because this may also happen. And we don't have double counting at all between the different modules, for example. So everything happens to be only once in our RAM. Okay, that's great. And it's just also to clarify, the RAM is the resource use. That's the user costs, right? Yeah, okay. That's basically what kind of services or resource use have you been used? So it's a self completion one, and the templates would be the ones to be used to develop at the organizational level. What are the costs? Yeah, for basically operationalizing the services. Yeah, maybe we can make. You can give us the link, and we can post them on our SIG web page of all of these instruments. If they are ready to absolutely. I mean, it's the last slide, and it's on the PECUNIA website, and I'm very happy to share it. And maybe it's another thing. I don't know whether it's interesting. We have now really a compilation of about 20 publications, and a few more coming out. So it might be also something that, if it's of interest, we could share the references, and this could be also distributed via the SIG. Super. Thank you very much, Judith. And for those who joined now, I don't know whether you would like to mention what happened. Yes, so we're really sorry if there has been a mismatch with the time. So the webinar was advertised a week ago with the old time, but because of the daylight saving in the US, which happened in the US but didn't happen in Europe, so there has been a mismatch. So for the people that are joining me from Europe or from other part of the world, we didn't have the time saving on. Sorry, because you've just missed it. So yes, I'm sorry, David, you're saying that the calendar expert gave me this time. Yes, so we're very sorry. We apologize for the mismatch with the timing. I don't know exactly what went wrong, but I think it has to do with the daylight saving in the US, which didn't occur in Europe. Yeah. But maybe, the seminar is recorded. Yeah. And if you have any questions, Judith, I can say that I can get in touch with you. Yeah. Feel free to get in touch. No worries. The recording is actually where? Can you look at this? It will be on our SIG website, right, Panka? Will you make it available? We will make it available there through the IEA. Yeah, maybe. Yeah. Yes, Panka has just dropped it in the chat box, where the link will be. So yes, people are joining now. Yeah. More people, yes. So if it's of any consolation, I also only found out a few hours ago that I'm supposed to present at 2 and not at 3 European time. So yeah, this just happens sometimes. Good. Yeah, it happens twice. Actually, it happens twice a year that the time changes. So yeah, we're not aware that in some part of the world it changes at different times. Yeah, good. But thank you for those who managed to join, and apologies for the one who are joining just now. But again, as I said, the recording will be online very soon. So I also would like to thank Chanel for the technical support. And yes, Panka, do you want to say a few words?
Nope, thank you so much, Judith, for taking the time to present, and thank you to the audience for being here. We'll see you soon in the next webinar.
Thank you. Thank you very much, Judith. Thank you, everyone. Bye. Bye.